don't know if anyone, my previous talk with this group was with opioids, opioid use disorder in pregnancy, and this kind of dovetails along with that. And I must say that I can't take credit for many of these slides as were modified from Dr. Tori Metz, who, as we go through this talk, you will see that she's the country's foremost marijuana expert as far as maternal fetal medicine. She was at the University of Colorado for several years and went back to her hometown in Utah. So she's at the University of Utah now. That's just recently happened in the last 8 months or so. She's a phenomenal resource, about as friendly and approachable person as you can imagine, and she was very generous in giving me many of these slides. So I would like to definitely give her a shout out. So as far as learning objectives today, we're going to kind of define the prevalence of marijuana use in pregnancy and the reported reasons for that use. We're going to discuss counseling women regarding the risks of marijuana in their pregnancy and lactation based on the best available evidence, and recognize and utilize available online resources that are available to clinicians regarding this topic in pregnancy. So some background: marijuana, by far the most common illicit drug used in pregnancy. It does cross the placenta, and as you can imagine, with the anticipated increased use and legalization, both for medical reasons and recreational reasons that seem to be continuing to progress through the country, there's an anticipated increased risk of use of recreational marijuana in the pregnant population. So where are we with this as far as legality? This is the most recent numbers that recent state statistics that I found. 33 states have legalized marijuana for medicinal use. There's 10 for recreational use. This year, those states listed have laws that are going to be passed or are up for legislation for a vote. And as you can see, Nebraska in 2020 is scheduled to vote for medicinal use for marijuana. If you want to look at a visual of this, anybody want to put a bet on who the last state's going to be? Kansas? Wyoming. Anybody else? I was going to guess like Mississippi or Alabama, but it's kind of interesting how it's moved through the country. So what is marijuana? It is the cannabis sativa plant. It contains over 600 chemical compounds called cannabinoids. Tetrahydrocannabinol is the psychoactive component of marijuana. There are also the different parts that have been used for therapeutics. The cannabinoids have a sedative and therapeutic effect, anti-inflammatory, that type of thing. As far as consumption, there are many different modes. Most people are familiar with the smoking or vaping, but more and more edible formulations have been produced, and there's also topical lotions and drops as well. So as far as getting marijuana into the system, what's the difference between smoking it versus an edible compound? Smoking has a faster onset, 5 to 15 minutes, and lasts for 1 to 3 hours. With edibles, you have a slower onset, and the peak effect is much later on. And so how that has implications is if you're using this recreationally, if you take an edible and it doesn't quite hit you where at the time frame that you expect, you ingest more and more, and eventually that builds up. And so actually emergency room visits for toxicity is increased with edible use compared to smoking it. So marijuana use in pregnancy, it's tough to get an idea of who is using and who is not. There's a huge difference in the literature with regards to self-reporting versus biologic testing, and we'll get into that a fair amount here. So it's all over the board. And so that's the reason there's a big difference between 3% and 30% prevalence in just about anything. And the reason why there's such a range based on the studies is most studies use self-reporting, which probably vastly underestimates the actual use. And so Tori Metz, again, this was just in this last month's Green Journal for us. She published an anonymous survey. So this is, again, when she was in Colorado, the hotbed of all of this, the laws and the legalization. So she basically looked at anonymous surveys of self-reporting at two different hospitals, so Denver Hospital and the University Hospital. And so based on that anonymous survey, roughly 10% who were coming in for OB care had ingested marijuana one way or another in the past 30 days. And again, she points out that this is probably underestimation of actual use. So how does prevalence change over time? Again, suggesting that with more lax laws and the ability to use this legally, that use would go up. And so just based on National Survey of Drug Use and Health in 2002 was 2.4%, 2014 almost 4%. Still fairly low, but if you think about it, that's almost a doubling of usage in the past 12 years, at least again in self-reporting. This is a little bit older data, and the point of it is that is there increased use with the legalization? So again, in Colorado, they looked at a time frame before legalization and after. And self-reporting, which is the bottom here, went up from about 5% to 8%, but urine toxicology went up from 15% to 28%. So it does suggest increased use with legalization. However, in contrast, when this study looked at meconium lab results in states that did not have legalization compared it to the state of Colorado, there really wasn't that much difference in the number of positive tests. Notably, the positive tests or the tests that were positive, there were higher concentration rates of THC in those samples. Does that make sense? And so this kind of refutes the previous slide as far as asking the question, with legalization, is utilization or more women using marijuana? So another big survey from the health department, basically 25,000 clients, a fairly large response rate of 1,800 women. And this is a trend you'll find, I think, in that women will use self-report using marijuana in pregnancy, and then there's a pretty significant drop-off after delivery and during breastfeeding. So I find that kind of an interesting trend that I wouldn't necessarily have guessed, but based on the data, it kind of follows that trend.
Does it tell you how long they breastfeed? If they only breastfeed a week or two versus 6 months, maybe that would.
Correct. So those that are going to be surveyed in a postpartum time period are kind of outliers in that they're probably breastfeeding longer, and so that might skew those. So that's a great point. And it brings up another point, that the data that we're presenting today and the data that is available is all over the board. And I think that point will be, brought home as we move through the risks of the pregnancy risk factors of marijuana use. we don't have great information, and it is a very difficult thing to isolate to assess risk. If you can imagine, people who smoke marijuana have a much higher rate of smoking tobacco or using alcohol or other substances. So it's a very difficult thing to isolate and associate with risks without considering all these confounding variables. So I think this is an interesting slide from the survey, is what is the perceived benefit of marijuana? And so they broke it down by people who have ever used, current users, or past users. And if you just kind of take a step back, ever users, they used it for fun. Past users use it for fun. Current users did not use it for fun. They were more likely to use it for depression, anxiety, stress, or pain with nausea, vomiting. So current users are at least perceiving that this is helping them with what I would suggest to you are medical conditions and not just for fun or recreation. Does that make sense? Especially when you compare it to people who have ever used marijuana or past users. Okay, I think this pretty much says the same thing, but women who use marijuana were more likely to report severe nausea. And so the connection between nausea and vomiting and pregnancy, and at least the potential for relief with marijuana, bears out in the reasons why women are using marijuana in pregnancy. It's perceived to work, whether that's a placebo effect or not. 90% of the women who did use it felt that it worked. Worth pointing out that I'm not aware of any study of marijuana being used as a treatment for nausea and vomiting in any randomized or prospective trial even to show a benefit. So again, as time goes by, people's perception of marijuana has changed, and this is similar findings from a 2017 study where previous perceived safety was around 3.5% in 2005, and pretty much has gone up no matter whether you have any history of use or no history of use. In general, the public, I guess you could say, perceives marijuana as more safe than they did 10 years ago. So just a couple of slides on how do we test for use in pregnancy or otherwise. Urine test, it can detect approximately use within the last 2 to 3 days for occasional use. However, if you are a chronic user, it can be detected weeks to months. As far as meconium, this is only used in the second trimester onward. Hair, you can get passive exposure, and then serum, it can detect 2 to 3 days of use. So a sample of cord can be used and tested in the neonatal period, and so the question is what's the best way to test for neonatal exposure? Meconium seems to be more sensitive, but both can be used. Does that make sense? And Kelly might have more to say on that, I'm not sure. So getting back to the difficulty in studying this particularly is there's a lack of quantification and timing of exposure. So if you have a substance that can potentially be in your system for weeks, what does that mean as far as when you have a test that's positive, how long has it been positive, and et cetera. So there's kind of a window of time that makes it difficult to assess. In addition, a lot of the tests are either positive or negative, and it doesn't necessarily give a value. So what are the concentrations, and do the concentrations of the subsequent drugs matter compared to just it being, positive or negative based on a really basic cutoff. And again, I can't stress this enough, the difficulty of and this isn't just in studying marijuana, but just studying anything like tobacco use or dietary indiscretions or anything like that. Self-reporting is notoriously poor in determining what a prevalence of something is. So this was in 1995, so several years ago. Maybe more people are more willing to admit that they do these substances now because it's more publicly acceptable. I don't know. But back in 1995, 70% of those with a positive THC screen denied using it. And so what does that do to the numbers? It's just, who knows? It's very difficult. So I'm going to focus on a couple of different perinatal outcomes here. The first one being fetal growth restriction. What does that mean? It means babies who in utero grow defined most often by less than the 10th percentile. There's some other definitions that include just the abdominal circumference of the fetus to make the diagnosis. When you compare moms who meet this diagnostic criteria with moms who do not, across the board, babies who are in the less than 10th percentile for whatever reason have higher incidence of stillbirth, of NICU admissions, of just about every neonatal outcome, adverse outcome, is higher in the smaller kids. So a lot of effort is expended to identify these pregnancies and screen them appropriately and watch them to avoid those complications. So it's a big deal in our field to not only identify but monitor pregnancies that meet the criteria for fetal growth restriction. So question is, does marijuana use in pregnancy increase the risk of fetal growth restriction? It's mixed. It's quite mixed. The gist of this study, I think, so does everyone feel comfortable talking about odds ratios? Is that something that we're good with? So basically, an odds ratio of 1.09, that's a 9% chance increased likelihood, okay? Now, unfortunately, in order to have that 9%, did I lose my, there we go. This needs to not cross 1. And so the fact that this does cross 1 makes this statistically not significant. Cool? So what's the difference in users versus non-users? And by users, greater than 4 times per week. The difference in birth weight was 131 grams. Not much, okay, in that study. Again, similar findings. There's a marginal decrease in the number of grams per week compared to non-users and those that were exposed to cannabis. This used ultrasound weights and not neonatal weights, so that's kind of interest and an interesting take. But again, not much difference between the two. So this is just a really, really great table. There's a lot of information. I don't know if we get copies of the slides or not, but this kind of summarizes all the available data. I can't imagine how long it took to put this table together. Thank you, Tori Metz. To emphasize the data source, to get a study where you can actually have biologic samples that you're studying is just, it's very, very difficult, very, very expensive. And so this really brings home the point that out of all of these studies, if you add up all of the study participants, you have like 90 that are actually biologic samples. And so it's just worth noting that we're reporting this data and demonstrating these differences, but of the non-users, how many of them are actually users? I mean, it's very, very difficult. These are kind of the bigger studies that showed no association with the difference with birth weight differences, except for regular use. This showed about a twofold increase. So what does this mean for us now, and how do we talk to patients? We'll get into that a little bit more, but I think it's unclear, at least with data on fetal growth, in utero growth, how marijuana affects. At most, you could say there's about a twofold increased risk of fetal growth restriction. So what does that mean? Let's say 8% of the population meet the criteria for fetal growth restriction. A twofold increase is going to be about 15% or so, 15-16% of marijuana users would meet that criteria. Okay? Let's talk about preterm birth. We all want to prevent that, don't we? Again, it's all over the board. So in an Australian huge study, self-report, there was about a 1.5-fold association with preterm birth. So again, if you see that it does not cross 1, that's a statistically significant difference. Similarly, using ICD-9 codes for substance use, there's this very significant increase in preterm birth, 18% versus 6%. However, in another study, preterm birth rates were the same between users and non-users, about 5%. It's helpful, isn't it? Again, to bring home the point, 31% with a positive serum screen reported marijuana use. So that's similar to what we said before, 70% denied it, well, 30% admitted to it. So pretty similar. And in this study, again, in 95, there was a slight increased risk of preterm birth in serum positive THC, but not if they self-reported. Make sense? More studies, and this is a positive study for a risk of about a twofold increased risk for preterm birth. Similar here. So if anything, based on the best available data, you could say that there is I would say a moderate increased risk of preterm birth based on the available data. It's about a twofold increase. Let's talk about stillbirth. Data is limited. Based on the Stillbirth Collaborative, which was a huge trial, multi-centered, happened to originate, or the primary investigators were at Utah. They did find an association between stillbirth and marijuana use when they used the cord homogenate positive THC. Okay. However, when adjusting for cotinine, which is the byproduct of tobacco or nicotine, so when they accounted for tobacco use, it reduced the stillbirth odd ratio by about 10%. So it's multifactorial, I guess you could say. But I think that's worth noting that when you have a positive biologic sample, and if you look at those women, there seems to be at least a higher stillbirth risk. Congenital anomalies, data is limited and mixed. So plus or minus, no associated major malformation. This is not a statistically significant study. Huge, large retrospective studies kind of use this as a variable, but nothing is really definitive or really a strong association. So currently, there's not adequate evidence that marijuana exposure is associated with any specific congenital birth defect. NICU admissions, job security. So this is one of the bigger trials from 2015, and there was an increased risk, again, about a 1.5-fold risk of NICU admissions, 12.5 to 17. That was statistically significant. Did they control for nicotine? Did they control for other things? Hard to know. So in this secondary analysis, they used a composite morbidity that included hypertension, stillbirth, small for gestational age, spontaneous preterm birth, and they found that it was similar between users and non-users, so it was non-significant in a composite outcome. Again, this table kind of summarizes everything. Interesting, the composite morbidity is significant, right? The p-value is significant. But if you ask yourself what is driving that, there's an infection morbidity that appears to be driving that positive result. And so this is a fairly nonspecific outcome. And so while you could look at it and say, hey, it's significant, as far as clinical relevance, it might not be as much as it appears. Different way of saying the same thing. So in another study that conducted, that looked at maternal, fetal, and neonatal exposure to cannabis from 6 weeks postpartum. So we're going to kind of move from the pregnancy-related issues to the neonatal-related issues. This study found an increased odds of low birth weight, NICU admissions, and anemia. What's a meta-analysis? Anyone? What's a systematic review? I think it's important to distinguish those two things because in some ways we love these types of studies. A systematic review is a description of all the studies out there on a given topic, okay? So, and usually it's confined to randomized trials if possible. And so the authors are going to do a big literature search on fetal growth restriction. And they're going to then basically describe the available literature and come up with some type of conclusion on that topic, okay? In contrast, a meta-analysis is doing the same thing, except it's going another step and actually performing statistical analysis on the available data. And for some meta-analysis, they ask the previous researchers for patient-level data. That's awesome. That's also rare. And so the difference between the two is that a meta-analysis actually gives you statistical numbers to compare to, okay? A lot of times those two things are combined in studies. So you'll read systematic review and meta-analysis, or a meta-analysis, which is really the same. But if you just have a systematic review, it's not necessarily going that next step of combining the available data to give us stats. We like stats. So in Connor's systematic review and meta-analysis, their goal is to estimate marijuana use, whether it increases neonatal outcomes, with the primary outcome of being low birth weight and preterm birth prior to 37 weeks. And these are all the other secondary analyses. So they found 31 studies total, pooled unadjusted data demonstrated an association between THC and low birth weight. So this was unadjusted. So they just plug in the data and say, is it significant or not? Okay. Adjusting is if they have 20 variables, is variable A, B, or C significant? And then of those that are significant, then they plug it in again and they do another analysis to see if, when combining all of those significant or semi-significant findings and adjust for those, what are the results? So this is what we really care about. When you adjust for those confounders, there wasn't really any difference in neonatal outcomes. Saying the same thing in a picture form for all you visual learners. It's kind of a fun. When was this? I don't know. 2013. So, a couple slides on neurodevelopment. I don't want to stomp on Kelly's topic. I haven't seen his slides, but if anything, there could be a neurodevelopmental impact on marijuana that is being discovered. So, in this case, they made rats smoke marijuana. Not smoke it. They probably just were in like a thing. And then they studied it, and they found then they killed the rats and looked at the brains, and then they found that dopamine receptors were reduced in the marijuana exposure fetuses. This was way back in 2005. Other studies on humans, kind of summarized in this table. Again, these are very difficult studies to do. I can't even imagine how much they cost. But in the different studies, again, there's some positive studies and there's some negative studies as far as outcomes. And so in this Ottawa trial of 180 participants, there were no differences in groups in neurodevelopment below age 4, although older than age 4, they noted increased behavioral problems, language comprehension, sustained attention, and memory difficulties. And so these longitudinal studies, as you can imagine, are very valuable and informative, but there's a lot of variables to consider. So in summary, again, I think this is maybe a helpful table. Moderate evidence that there's decreased growth, decreased IQ scores, decreased cognitive function, decreased academic ability, and decreased attention. Okay? There's limited evidence of stillbirth, SIDS, depression symptoms, delinquent behavior, and isolated VSD. There's insufficient evidence to say that there's psychosis or future marijuana use, and all of these are mixed. All the ones we care about are mixed. That's not true. We care about all of it, but. This is fascinating. I don't know if you guys like to read journal articles or not. I do, and it's fun to look at some of the like classic older articles that we like base everything on, and how much has changed from what was originally reported in this landmark article and how we quote it and how we use it on a daily basis. It's just a fascinating thing. So the initial study in '82 from the New England Journal of Medicine that talked about THC in breast milk was a letter to the editor of 2 patients. So this was not even a study. This was just like a commentary, right? And demonstrated that chronic heavy users had up to 8 times plasma doses of THC. So it just kind of puts things into perspective a little bit, I think, that when you just say, well, that New England Journal landmark study, it sounds really smart, but then if you look at it, it's just a letter to the editor of a case series of 2, okay? What is the breastfeeding implications of THC use? So this was an observational study of 8 women. They purchased product with known concentrations of THC. They abstained from use for 24 hours. They inhaled cannabis, then collected their breast milk at 20 minutes, 1 minute, 2 hours, 4 hours. Exclusively breastfed infant ingest about 2.5% of the maternal dose. Okay, so it does cross. It is in breast milk at a much smaller percent. So as you can imagine, the amount of use is going to correlate with the amount in the breast milk, and that's what this study has concluded. So another study in 1990 assessed neurodevelopment in babies who were exposed via breast milk, and those exposed scored poorly on psychomotor developmental index, the PDI, compared to non-exposed. The difficulty is they were unable to separate prenatal exposure versus postnatal exposure. So what does the ivory tower? What's the current status of what they recommend? So the American Academy of Pediatrics, marijuana use during pregnancy and breastfeeding. That's the name of the statement. Present data is insufficient to assess the effects of exposure of infants to maternal marijuana use during breastfeeding. As a result, maternal marijuana use while breastfeeding is discouraged. Does ACOG agree or disagree? Very simply, women should not use marijuana during pregnancy or while lactating. OBGYN should not prescribe for medicinal purposes to pregnant or lactating women, and there's insufficient evidence for effects on nursing infants. So essentially, the two main organizations have concluded, based on their evaluation of the available data, very similar recommendations. So this is an interesting recent study, and there's more and more kind of studies like this that I kind of value because they're not just data driven. It's kind of like how are we talking about this, and what are we doing about it? And so this is a study that recorded patient encounters and evaluated the provider's response to disclosure of marijuana use. And so in this study, about 20% reported marijuana use at their OB intake, and this was dispersed over 47 healthcare providers. Half the time, basically, the provider didn't even respond to the marijuana disclosure. And when discussed, it was very nonspecific and focused more on toxicology screens and social service involvement rather than what the potential risks or benefits to them in their pregnancy. Interesting, right? So this was kind of a nutshell summary of kind of what was talked about by the provider to the patient. So, and this is probably videotaped, so you can't deny it, right? So you know how it alters your mind when you have it, how it makes you feel. So think about doing that to your baby, even though it's not formed yet. It gets the effects as well, and we don't want you to do that to your baby. Like, this isn't helpful. And similarly, we like to make it punitive, right? And so we focus on the illegality of it, even though in 10 states and probably the country after a while, it's not going to be illegal. But at the time of delivery, they'll do a urine drug screen because you have a history. If it's positive at the time of the delivery, they'll have you force you to go to Child Protective Services, blah, blah, blah. This is how we're discussing marijuana use in pregnancy. This study is my favorite one. It's toward the end of 2018, just came out in our Green Journal. So this was called the Mystery Shopper Study. And so this was, again, I believe in Colorado, where they basically selected 400 random dispensaries and then had a fake pregnant mom call them and see what they were going to tell the pregnant mom. So they called in saying that they were 8 weeks pregnant with nausea. Okay, 70% of the 400 had THC recommendations for that condition. They at least predominantly recommended edibles, which is nice, right? Except if you overdose on them, because you're more likely to overdose on them. And they were based on personal opinions, not they didn't say, well, these studies or that study. It was just like, hey, you should try this because it helped me with nausea once. And only 1/3 recommended discussion with their healthcare provider without any prompting. So the the interviewer would kind of give the person on the other line at the dispensary an opportunity to say, well, should I talk to my doctor or da-da-da? And only about 1/3 did it without that prompt. Kind of cool study. Finally, again, Colorado is kind of the head of the sword or snake or whatever that saying is, as far as not only being on top of the research, especially in the perinatal populations, but just in general, I would say. And so they have a lot of great clinical guidelines. They have a lot of great handouts. I think one thing we can learn, and one thing hopefully I'm modeling here, is that we don't need to reinvent the wheel. If you have someone who's the national expert on it, borrow their slides, because they're better than what you could create on your own, okay? And similarly with patient brochures and educational material, this stuff is out there, and it can be easily adapted to our purposes and in our current legal situation, et cetera, in the state, and helping the women that we provide care for here. So what should we tell a patient? There's clearly no known benefit at this time of marijuana use in pregnancy, and there are clearly possible risks in pregnancy, as we outlined today. We should not encourage marijuana use in pregnancy, and there's not a known safe amount, whether it's a little or a lot, or eating edibles is not any safer than smoking it or anything like that, okay? Is this generic? Is this satisfying? It's not, admittedly. I wish we could say more about the risks or non-risks, but I don't think we're there yet as far as the data. Like everything, we need to do more research. And that's all I have. Any questions at all?
When you discuss risk with your patients, do you usually discuss like preterm birth and low birth weight as inclusive but possible, or do you usually kind of leave it vague?
Yeah, that's a great question. And so the way I interpret the data on the risks in pregnancy, as far as really the growth restriction, preterm birth, and stillbirth are kind of the biggest ones. If you look at the risks of tobacco use, and by tobacco use, smoking 10 or more cigarettes a day, it probably lands around that similar risk. And so in my mind, if I'm going to counsel a mom on tobacco cessation and the risks of tobacco, I'm going to kind of use a similar kind of discussion when talking about marijuana use in pregnancy.
Do you think since medical marijuana is being more acceptable, it's more legalized now, do you think we'll be able to get some better studies?
Yeah, I should have. I'm guessing that they're ongoing, and or will be soon. Yeah. It's hard to enroll a pregnant mom in a study in general, and if you can imagine the informed consent that it would take to enroll a mom in which you are giving them either THC or a placebo, it's just really, really difficult.
Regardless if it's THC or other illicit drugs, do you find doing like the neonatal, or maternal urine drug screen and then following it up with like a neonatal urine drug screen, meconium before?
Mm-hmm.
Is that overkill, or do you recommend doing all three?
We recommend, currently ACOG recommends screening for illicit drug use, and that is a questionnaire. It's not a biologic sample. And then if there's a positive screen, then further inquiry is warranted. I think that it is a very open question of doing biologic screening. There's a lot of social determinants, and you kind of can run into some difficulty if you just kind of select the people you want to test and not test. Similar to the opioid epidemic and the testing and screening for opioid use, some would say that it should be a universal thing or not. And so if it's going to impact your medical therapy or treatment, then that's warranted. So at least as far as my understanding of the difference between testing during pregnancy and neonatal testing is if there's signs or symptoms of withdrawal or something that would prompt a toxicology screen in the neonate, that's warranted. But it's definitely not, I don't think anyone encourages just universal biologics testing that I'm aware of. I could be wrong, but that's my understanding.
What about for those mothers that when you screen them with the questionnaire,
Mm-hmm.
say yes, I have been using during pregnancy, then what screening would you recommend after that?
We would counsel them on not doing that anymore. I don't know if
Would you do a biological, like a urine sample at that point if they admitted to using?
not necessarily. I would say that if it was going to impact how I would recommend surveillance or monitoring the pregnancy, then yes. I'm a little bit skewed in that if patients are coming to the high-risk clinic, they're going to get a certain level of surveillance that's at a much higher level than if they weren't in my office. So it's probably not going to change much of what I do. And so I wouldn't necessarily feel compelled to do testing.
You lean more towards counseling.
Correct.
Okay.
And we have to be cognizant of the times that we're living in and the likely changing dynamics of what the laws are and things like that. And that's a moving target. And so it's illegal to use marijuana. Whether what the criminal punishment is for that and not is also a moving target. But I think it's kind of difficult to blow it off completely. But things that are legal, we don't blow off completely either. So again, to correlate it with how I kind of think of it, it's similar to me as any other substance like tobacco or alcohol or other even prescription medications that can be abused or impact an outcome in pregnancy. And so I kind of put it in a broader set of terms, I guess, in that way. Thank you, guys.